Hi, everyone, and thank you for tuning in. We're so excited to bring you another amazing lineup of thinkers for this conversation, our fourth in a series of 5 dialogues, where we're exploring what it's going to take to build a more resilient community health system in the future. So today, we're looking at what mechanics and structures are needed to support and elevate community health, and also what can we learn from existing examples and case studies and how these models could scale. So the importance of community health, I think a lot of people have noticed, have really been foregrounded during the COVID pandemic. It really feels like countries that have invested in this have done a better job of managing the pandemic in a lot of cases, whereas countries that didn't, less so perhaps. And interestingly, there is a real call out there right now for more resilient healthcare systems. But resilience, it's not just about emergency response. It's also about the ability to adapt and grow in response to stress. And right now, there is that opportunity to explore how the lessons from COVID-19 can help us to reshape some of the mechanics and structures of our community health systems so that they are more proactive, more responsive, and more equitable. My name is Ivana Gazibara, and I'm the host of today's conversation. And in my day-to-day, I lead the Future Center, which is a participatory digital platform for tracking trends and signals of change, making sense of what's emerging in the world, and just building communities that can drive positive change across a range of sustainability challenges. So the Future Center has partnered on this work with the Johnson & Johnson Center for Health Worker Innovation. And it's a project which essentially aims to build a shared understanding of how COVID is impacting our societies and just distill learnings about what that means for how we design and run and build more resilient community health models in the future. So we're running a series of dialogues across 6 key questions, which we feel are really fundamental to health systems. And also to transforming community care more specifically. You can find out more about those on thefuturecenter.org. And for today's conversation around the mechanics and structures that we need to support community health and learning from existing innovations, I'm joined by 3 amazing thought leaders, each of who's approaching this question from a slightly different angle. So I'm going to let them all introduce themselves and say a few words about their work. They also got a small bit of homework ahead of this conversation, which was to choose an image which to them personally exemplifies the community health system of the future. So I'm also going to ask each of you to share your image when you introduce yourselves and just tell us a little bit about why you chose that particular one. So Reg, can I start with you, please?
Yes, absolutely. Hello, everyone. My name is Reg Joseph. I am the CEO of an organization called Health City. It's a not-for-profit organization. We are involved in looking at taking large technology platforms like artificial intelligence, augmented virtual reality, IoT, and transforming them into healthcare practice. And do you have the image? Oh, wonderful, great. So I chose this image just as one example of many technologies that are sort of transforming the healthcare landscape. This is 3D printing. So quite often when we think of 3D printing, we look at the top left-hand corner where we think of developing new organs and printing hearts and printing kidneys and all that kind of sci-fi type of stuff. But when we really look at the practical implications of some of these technologies, the bottom right hand is 3D printing technology in rural Africa right here. And I think these folks are printing umbilical cord clamps. So the ability for us to start to look at these transformative technologies in a very different way from being sort of sci-fi and futuristic, which is kind of cool, but I think there's much more pragmatic uses for many of these technologies. The interesting thing about this 3D printer also, it's completely solar powered, so it's off the grid. And so providing capacity in communities with technology for self-supply is kind of where I like to see our health move in the future. So that's me.
Brilliant. Thank you for that. And what a good reminder, actually, of like how diverse the needs of our health systems around the world are. Maurice, can I go to you next?
Yes, sure. My name is Maurice Cook. I am a researcher at the Kid Royal Tropical Institute in Amsterdam, but actually I'm based in Malawi. My research is focusing on community health and particularly the role of community health workers. I have chosen a picture that is quite broad. It's more like how you want to see the outcome of health, and health in the sense of a broader definition of health, really the well-being component. The sun is shining on this picture, no sign of disruption, no sign of inequality, but really feeling good and feeling well. So that's why I chose this picture. Thanks.
That's great. Thank you. And Nan.
Hi, everyone. So my name is Nan Chen. I am the Managing Director of Health System Strengthening at Last Mile Health. And Last Mile Health is an organization that works with governments to design and deploy their community health systems. We've worked we're rooted in Liberia, West Africa, and have since started working in a few other countries. And so the picture that I chose, usually when I'm asked to bring in some pictures, I often bring in pictures of community delivery, so a health worker delivering services at the community level. But with this, when thinking about the future, I thought I wanted to bring in something a little different. So this was a conference a few years ago that brought community program designers and government officials from across the globe, some from Bangladesh, from Liberia, Kenya, Malawi, and others, as well as government stakeholders too. And what I thought was really interesting about this, and what I'd like to see in the future, is a lot more formalization and almost like maturity of the sector, where we're learning from each other, having a sense of a cohesive policy agenda and learning agenda, and getting almost that shared vocabulary where we can really supercharge the learning across countries and across programs. So this was a place where I felt like we got a hint of that a few years ago.
That's great. Thank you. Brilliant. So I'm going to kick us off with the conversation in a second. But before I do that, I just want to cover off a few small points. One kind of has to do with the structure of the conversation today, which is really just about briefly introducing the Three Horizons framework, because that's how we're kind of going to run the flow of today's chat. And what it is just a framework for structured thinking about the future and about transformation more broadly. So it's premised, as the name suggests, on three horizons that are playing out at the same time today, but each also contains seeds of the future. So on this diagram, the x-axis tracks time and the y-axis tracks prevalence. So if you look at the first horizon, that's our status quo today. It describes our current context and conditions, our working assumptions, and just broadly our kind of dominant paradigm. And necessarily not all of the ideas and practices and concepts on the first horizon are fit for the future. So that's why you see that line curving down as time goes on. So this is the conversation bit where we're going to be talking about what's dominant today, but what might be in decline over a longer time period. The third horizon describes the future that we want. So for that bit of the conversation, we're going to do a bit of visioning together. And the seeds of that future are very much present and visible today. It's what we often describe as a new trend or an emerging innovation. So the sorts of things that might be quite weak signals of the future today, but if they grow and they mainstream, they can come to form the new paradigm. So the third horizon in the distant future is what replaces the first horizon. And the second horizon, which is perhaps in some ways the most interesting one for present day conversations, is the space of disruptive innovation, of kind of new ways of doing and being, and a space of change, a bridge between the present day of Horizon 1 and the future of Horizon 3. So that's kind of how we're going to flow from Horizon 1 to Horizon 3, and then back to Horizon 2, where we're going to consider finally how to create that bridge between the present and the future. And the second thing to mention is this Miro board that you're seeing. So that's just kind of like our online whiteboard for the project. We've got one for each dialogue in this series, and every time we host a conversation, we're essentially layering in more and more insight onto the Miro board. And we're going to also share it on the Future Center on the project page, so that anyone participating in this project, or just kind of watching and listening, can share their comments on the discussion boards, and so that we're kind of layering even more insight into the process in a participatory way. So it's also kind of tool for ideas exchange, I guess. So having said all that, I'm going to dive right in, and I'm going to take us to the first horizon, which is where we're thinking about the present, our status quo, and the business as usual of today. And I guess really my first question to all three of you is, what do you see as the dominant way that we do things in community health today? What's the kind of business as usual?
I'll jump in. From a Canadian perspective, I would say, compared to many other jurisdictions around the world, I think community health is very disjointed, and it's siloed. And so we're very much tied into acute care, and putting in a lot of resources into our hospitals. And our hospitals are very centralized. In the region where I'm in, the acute care region is bundled together. So it covers a population of about 4.5 million people, and it all has to go through sort of a centralized locale. The challenge with that, or I guess the opportunity there, is that, you know, you've got this sense of standardization for the entire population. But the real problem is that because it's centralized, because it's tied into large municipalities, quite often small communities get lost. And so their ability to actually care for themselves, being able to drive care from the communities, by the communities, for their own people, is actually very challenging. And as a result, we're missing a lot of folks, and we're definitely losing the battle against chronic disease prevention and management. So I'll pause there right now.
Brilliant, thank you. Nan or Maurice, do either of you want to build on that?
Yeah, I could definitely. That resonates a lot with me, Reg, in terms of some of the places that I've been working in the last few years. There's almost been this, I feel like a lot of places we're in a transition phase from pure like informality and fragmentation, as you started mentioning, to a place where, as you said, there is a little more standardization, but not standardization of quality, right? And equity, let's say. So an example of that is just in our work in Liberia post-Ebola, there was standardization. The government supported and developed a new policy, which went from pre-2015, it was all volunteer-based, fragmented, inconsistent training. There wasn't like a standardized curricula, and most of it was done by government cadres of community health workers, and others by NGOs and other donor-funded organizations. Some of those worked really well, but what worked really well did not actually, scale to the actual quality. So they're in that transition phase now where there's more standardization, but I think the next big thing is how do we get to quality, equity, sustainability in a way that's right for all, but also right for the local context.
Why do you think it was that the sort of best practice did not manage to scale? Was that just unique to that particular context, or are there sort of more systemic barriers that you think are preventing that standardization of quality?
Yeah, I think it's certainly not unique to this particular context. I think the general research in the last 30 years on community health, such that there's a lot of research that suggests at a, when we have these pilots, when we have these really well controlled and tidy interventions on, let's say, if we are delivering malaria diagnosis and treatment even at the rural community level, at the small scale, we get some pretty good results. And even in our own work, we get some fairly good results. But as we kind of move out, I feel like the next pieces of the research agenda are, how do we maintain quality as we scale? How do we work across different partners? If it's not an NGO doing it, if it's doing it with government, or even doing it across several partners of service providers, how do we maintain that kind of quality management? I think there's a lot to be said for the upstream work on policy and financing and politics, and then the downstream work of delivery of services, managing those services, and learning from that we're kind of scratching the surface on, I think.
Got it. Maurice, I'd love to hear from you on the kind of health worker perspective in all of this. What does that landscape look like, particularly where you are in the field?
Yeah, from my experience in Sub-Saharan Africa, I think I recognize what Nan and Reg have been saying about there are lots of initiatives and a lot of good examples of what works, but not so much at scale yet. Also, if you look at community health worker programs at scale, we do have some good examples globally, but they are still quite a selected number of them. I think in many contexts, there are so many different partners working on it, but still a little bit on their own. And as such, efforts and funding available are not pooled. And then you get the silos. From the health worker perspective, also what I've seen in my work when researching community health and the frontline health workers that are there, I think it's not all that negative. There are very nice initiatives going on, and also like the day-to-day practices of these workers, they are recommendable. They are good. Many of the times you can see that they have found their ways of how to cope with different circumstances. So I think we should really not forget that there are a lot of good examples on the ground. That health workers are making the best of the resources and the circumstances that they have. And in a way, sometimes we should try to learn more from those experiences, and also get those voices of the health workers into policymakers and other organizations and programs that are trying to improve and help them. So I think that's what I have to say now. Thanks.
Yeah, that makes a lot of sense. And it's interesting, as you were just saying that, I sort of thought we talk about how to create more resilient community care systems, and actually community health workers, they really seem like the definition of resilience and adaptability in so many ways. I was actually you've kind of created a brilliant shortcut, because my next question was going to be we've spoken quite a lot about what's disjointed and what's broken. Are there things that are working well today, beyond what you've already mentioned, Maurice, that you think are important for us to kind of keep and scale as we move forward?
Yeah, there are a lot of things, I think, especially engagement of communities. There's a lot of research around that, and also a lot of research that shows that it is quite limited and that there are a lot of constraints. But there are other examples where communities are really part of claiming the health services that they want, and being part of decision making and planning at that level. often facilitated by community health workers, but sometimes also more coming up naturally. So I think that's very important because social accountability systems, after all, can really contribute in improving health services. Yeah, let me leave space for the others to also comment on this.
Reg, did you want to come in?
Yeah, sure. So in Western Canada, one of the challenges we have is healthcare provision for our First Nations communities. And it's night and day. You know, some of these communities are very closely located to large municipal centers, but their access to care is very, very different. And so some of the new initiatives that are just starting to kick off now is this whole idea of providing capacity within the community, particularly culturally sensitive capacity, so that the communities can provide healthcare to their own people. So, we've got these communities that we call them First Nations. They're run by Indigenous communities, and they have their own belief systems and practices. And quite often, the health system is at odds with those practices and beliefs. And so now, we're just starting to get snippets of this, where some of those nations are starting to say, we are actually positioned to be able to provide care for ourselves and be able to provide care for our own communities. And so they can do so in a way that, of course, is going to be culturally sensitive and so forth, but also effective in terms of behavior change and prevention and so forth. So I'm seeing a glimmer of hope of where that could be in the future, but we're just starting. And of course, there's going to be in Canada, in dealing with those scenarios, there's a fair bit of bureaucracy that needs to be dealt with, both at the provincial level and at the national level. And so we're just going through some of those machinations right now, which, it'll be a long and arduous track, but I'm starting to see the beginnings of it. So.
Great. Yeah, and what an interesting example, actually, of kind of building capacity within communities to take care of communities. I love that. Nan, obviously, last mile health does kind of what it says on the tin. It sort of covers that last mile. Any kind of perspectives from that work in terms of what you're seeing working really well?
Yeah. Well, I wanted to mention, I think, this conversation stands as a part of a long dialogue, right? And so, for example, when thinking more optimistically, let's say, if I look at places like Ethiopia and Bangladesh that have had these really huge programs, and not even singular programs, sometimes very pluralistic, multifaceted programs. Like Bangladesh, they had achieved since the 80s, I think, up to like a 90%, roughly 90% vaccination rate for child immunizations, starting from near zero in the 80s, and this is through the Millennium Development Goals around 2015, right? And I'm sure they're continuing that program. They similarly with under 5 mortality had reduced it from 1990 to 2015 by 75%. With the huge contributions by the community sector that they were programming there. And this is, I think Ethiopia did a similar thing since 1990, decreasing by like 60% their under 5 mortality using primary healthcare, community health systems and programs. Which is to say, even before this conversation today, there's been a huge amount of progress, even before some of the things that I think might supercharge is like some of the digital technology and the integration of data systems and feedback and learning. There's places where I think this has worked quite well before. I think the challenge before us then is how to adapt from what's worked kind of on a paper-based system or what's worked for 30 years within certain types of contexts to making this work everywhere. And I think a few things that really stand out to my mind, as I mentioned, one is how we bring together technology, data, and learning systems. So imagine at the beginning of COVID, let's say, this is what happened in Liberia. We found out about a new, a new disease threat. Imagine if we would have found that out much quicker. And then we had to write the training curriculum and protocol, and then deliver it in person across to many of the community health workers. So imagine how technology could like shortcut all of those by several days, maybe weeks, and how as this pandemic evolves, how we can quickly get new information out to our health workers and to our health communities. So that's one thing. There's another piece here on politics that I'd love we can talk about here, but for now, maybe I'll just mention that one thing about how data and learning could really supercharge our systems.
Yeah, great. And we'll get into all of that, I think, in the next bit of the conversation, because I want to invite you now to do a little bit of visioning for me. So moving from, what does the system look like today to looking at what is the future, what should the future look like rather? So what could a different community health paradigm be in the future, and what are the kind of features of that? And I'm just going to pick up on that tech point that you were making, because I do think that a dimension of this has to do with technology. And I'm curious to hear from all of you, and perhaps first, Reg, from you, given that Health City sort of focuses on deploying technology platforms into the healthcare space. How might we be using data to kind of empower community health models in the future?
Yeah, good question. From a technology perspective, I think there's a number of technology platforms that could be really interesting, but data is the one that you chose. One of the interesting things that we're starting to embark on here is to start to look at how do we combine acute care data and social indicators of health to drive new models of care, right? And so right now, when we are doing public health policy, there's very little inputs from social indicators of health in determining that policy. Yet, we actually do have a lot of data at the municipal level from different organizations that we can tap into. And that's where the advanced techniques like artificial intelligence, machine learning could really come in and start looking at interesting patterns and opportunities for health improvement. So really, for us, it's a culture change in terms of being able to look at data as now a source of input, true input in terms of being able to model and look at health systems in a very different way. Right now, the way we're using data is in a very linear method. Acute care centers collect their data, they look at admission rates, they look at costs, and most decisions around public health are driven by those drivers. But as we can see, and it's actually exemplified here in Canada, that making decisions based on those drivers are not increasing health outcomes. And actually, our health outcomes in Canada, when we compare ourselves to other jurisdictions around the world, is actually dropping. And so it's clear that that model is not working, and we have to look at different data models to drive decision-making in healthcare.
And can you give us an example of what different might look like? Are you seeing it already happening somewhere?
Yeah, I mean, we're just starting to embark on this idea of, can we start to combine data sets and start to look at things differently? So, and even that in itself, from a bureaucratic perspective, is driving a lot of brick walls. So it is challenging because the culture is that those kinds of data sets are not important to driving health, and so the systems are not set up to be able to accommodate that. And then the secondary challenges is that trying to do it outside of the system is also problematic because of privacy issues. So we're actually developing some new techniques that actually enable us to manage the privacy issues and work outside of the system to try to bring that intelligence back into the system and see if we can drive change that way. Yeah, it's an interesting process.
Interesting. So actually, we're kind of working outside of the system to transform the system.
That is
right?
correct.
Yeah. And Nan, you were mentioning policy and politics a second ago and wanting to kind of take that a bit further. What's the enabling context around that stuff that we need for the future of community care?
Yeah, I was thinking about this as much of a sort of tech and data geek as I am, and I certainly am. I talk about that for quite a while. It feels to me that I mean, Rich, you mentioned this, where like even when given the data, or even given the data as raw, sometimes we don't end up making the best choices for maybe our most vulnerable communities. So I've been thinking about this idea that public health is a political choice and not just a technical one, and how actors like ourselves here, or those champions within a government agency or Ministry of Health, ought to think much more like reform actors and using collective action ideas, and so the work that we're doing probably looks a lot more like a decades-long advocacy movement than sort of a pure R&D approach. I think one example of that right now that's very close to the work that we're doing is, we're obviously seeing with COVID-19 vaccinations a divergence where where I'm here, the country that I'm living in today has almost 70% vaccination, whereas less than 1% has been administered in low-income countries. And so I'm wondering if 5 years from now, is COVID-19 going to go the way of malaria and HIV and AIDS and TB, where it's no longer called a pandemic because it's not affecting rich countries anymore? And how might we borrow lessons from our colleagues in the climate world to make clear that local public health is actually a global public good that we all want to invest in? And I think then, just to make it more practical, that probably changes the conversation for when we have to engage with heads of state or ministries of finance or the purse strings that might not see the technical health issue, but can certainly feel the political pressure when their executives call upon it.
I love that point about local public health being the global public issue. That makes a lot of sense. And Maurice, do you want to come in there? I'd love to hear what your response to this kind of policy and politics point, but also to hear about kind of the health worker of the future. This is, I think a critical question for this field as well, is what will the workforce look like? And where will it come from, and what's going to enable it, all that stuff.
Okay, thank you. Yeah, about the politics, I think maybe the COVID-19 pandemic again stressed these interlinkages between health and other sectors, the economy, but also the veterinary sector. And I think that is also, if you look at community health, it's already complex on its own to run proper community health worker programs and the like, but to really look at it a bit more from a broader view, that these health workers, they have a lot of insights about what is happening in the community when it comes to economy, when it comes to agriculture, possible shocks that are there, or that could come up, so preparedness and the like. So it's really a more holistic view of all these different sectors that are interlinked and that, after all, are affecting health. So I think also, if I look at the future that this connection should somehow get more attention than they have so far. Your question about the future health workforce, I find it a difficult one. Need to think about that. Yeah, the health workforce is very diverse and should be diverse because, yeah, if we would like to have equity in health, then the health workforce should also be able to represent different groups. And that might not be the case right now, also just because, yeah, certain groups maybe have less opportunities to be able to become a certain group of health workers. You see it now in the community health workforce that there are mainly women of different education levels, and there are also yeah, this viewpoint that's actually not a good thing because it should be more diverse, and also has to do with their remuneration. They should be, you know, properly paid for the task that they do and the time that they spend on what they do. So this kind of discussions are all right now there. But they are equally important as we look ahead to the future. That we need a health workforce that is diverse. We need a health workforce that is looking at quality and has the appropriate support to be able to do what they need to do. So I think for now that's what I'm thinking.
And I think that diverse workforce point picks up nicely on what Reg was saying earlier about kind of the example of First Nations communities and getting local community members to take care of the rest of the community. It feels very kind of, as you say, important to have that if you really want equity in the system. Welcome back, Nan. And so all this stuff is really both fascinating and really critical. So, and I know, Maurice, that for instance, something like they say 3/4 of community health workers in Africa go uncompensated. And are, you know, just broadly speaking, as a kind of field, it's an under-resourced field a lot of the time. So is there something around kind of financing mechanisms and how well or poorly that is supporting the future of community health? What do we need to see in this future for this part of the health system to be sustainable? And I feel like probably today it's kind of functioning off of philanthropic donations quite a lot, you know, financing mechanisms that are perhaps not the most sustainable over the long term. How do we shift that? And, you know, are you seeing new models emerging in that space already?
Well, yeah, new models, I don't know. First of all, I think it is, again, this political choice and political will, because there are good examples globally, as we've already been discussing. I think generally, and that is also something that has been already there for a long time, I think there is this tendency to underfund preventative health in comparison to curative sector. And yeah, maybe again, somehow the pandemic might have reminded us of that, because yeah, prevention after all is better than cure. And a lot of the community health workforce is really focusing on promotion and prevention. And of course, treatment of minor illnesses can also be done at that level. So it's foremost, I think, really, there is, of course, in many countries not enough money to do whatever you want to do when it comes to the health system. But I think that the division of where the money goes to could be improved to to have more attention for community health. So that's first. And then the models. I think there's quite some research about different models and how to pay or incentivize the community health workers or the frontline health workers. But what is also being recommended lately by WHO, and I really want to underscore that a proper remuneration and a proper salary is in most cases just needed. So you could think about modalities of like, community health workers could partly sell commodities, and that is then an income source, or they could be paid for performed tasks, and then and in that way they can get an income. Or even communities can contribute to incentivizing community health workers. That is also being done. Different types of goods or services that they get from the community side. That's all possible, and it is all being looked at. But I think still there should be this integration of these health workers into the formal health system. They are part of it, and they are a very instrumental part of it, and therefore they should also get the how you say, the remuneration and the how you say that, they should get the acknowledgement that other health workers that might be at a higher level also get.
I'm going to jump in if I may. One of the things that I see, things that might be changing, and I think Maurice and Nan will probably have real life experience with some of the projects that you're doing, but I'm starting to see the lines being blurred in terms of this Western notion of what a healthcare worker is, and that specific role might start to get blurred and changed over time. So again, in my projects that I'm working on with First Nations, we were looking at doing some remote-based diagnostic imaging, just because imaging was a challenging accessibility factor. So what we did was we brought imaging technology into the nation via handheld imaging devices using AI backend. And because those devices are so easy to use, you don't need medical training in this case to take high fidelity images. And so you could now have an average member of the community imaging, wirelessly sending those images to a radiologist for diagnosis, and it didn't have to be an ultrasonographer or a technician taking those images. And so and in this case that I was talking about specifically, the community, it was a community issue that they were trying to resolve. So they all wrapped around and said, yes, we'll make this thing happen. Did they have all of the capacity in terms of having the right number of healthcare workers to do all the screening and so forth? To be frank, I don't know. But it kind of didn't matter because the community just came together and said, this is something we're going to get done. And so I'm seeing this sort of Western notion of what a healthcare worker is and does, might start to dissipate a little bit as we start to look in the future. And Nan and Maurice, I'm wondering what you're seeing actually in the field, because you're probably experiencing that already.
Yeah, I love that example you just gave, Reg, where what I really liked about it is of course there's the tech-enabled element, but part of this is actually not just the frontline community health worker, him or herself, but how she works with teams, nurses, supervisors, even specialists, right? And that ability to consult, do what you can with technology in the community, and then consult with others. We've seen this in our work where really more prevalent, or rather more precarious cases really get referred to the local facilities. And so whereas some family member might have been trying to deal with a case of severe malaria just at home and trying to treat it as if it were a sort of a routine case, now we're seeing that connection and really and getting moreover getting the local public and primary healthcare system involved in this. So it's kind of all capturing within the same system. So I think that's right, spot on in terms of where this could go. I think the other part of this that I think you're sort of implying as well is in a future where these community health workers in the systems that they operate in aren't going to be static, or they don't have to be static. They can kind of adapt with evolving epidemics or evolving needs as the community of their communities themselves. And as we have to work on both the human, the soft side of this, of how to like continue building and evolving capabilities and competencies, and also probably the data and the hardware side of this. But I think if you can imagine like a future where that could occur, you start seeing where perhaps the current architecture, the pipes in the system are a little bit misaligned to allow that kind of both incentive flow, motivation flow, money and data flow. Yeah,
Okay,
it's really
can
exciting.
let's pick up on that, actually, the architecture. So this is probably the hardest question in some ways, but possibly the most important, how to kind of make it all happen. So we've just talked about some key elements of what a better community care system would look like. What is the architecture that can sort of help to scale that stuff up?
Yeah, I think it's going to be an architecture that has to be really driven by decentralization, driven by democratization in terms of accessibility to both care and tools, and that's going to require infrastructure, but not the infrastructure that we typically think of in terms of you need to build a clinic in a community. In this case, it'll likely be wireless access, to be honest, right? Because what we're looking now is virtual care type solutions that actually enable communities to actually care for themselves. But if you're not on the grid, it's going to make it really challenging, because then to plug in, like you mentioned, say, okay, well, hey, we're taking images here, or we've got diagnostic work here, and we now need to consult. You now need to get on to that infrastructure to be able to do that. I think that that infrastructure is far less costly than building hospitals and clinics all over the place, but it's still significant investments. And to what Maurice said, it's infrastructure that you're trying to build on the prevention side of things, and that's always harder to get dollars for. But that's where I think we need to go. We've done similar models in education, and I think we can do that in health as well.
Maurice, I want to hear your perspective on this. So basically more wireless infrastructure rather than sort of clinical infrastructure and prevention infrastructure. Is that what you're seeing through your work as well?
I think yes, it will definitely need to go that way, more wireless. At the same time, we also still need to invest a lot in relationships between the different health workers. I really like what Nan was saying about community health workers being part of a team. And indeed, the relationship between the different team members also makes it that they can work together and that they can refer cases to each other, whether it is face-to-face or online. I think we should go both ways. And in many settings, it's needed to go both ways, I think, still. When it comes to infrastructure, I really agree with Reg. I think about decentralization, democratization. I can imagine that about this Western idea, what you were saying, or maybe not Western, but this idea of the health worker. Yes, I think also in a lot of countries where I've been working in Sub-Saharan Africa, there's quite a lot of protectionism about who could do what and who should do what. And if in the future we are going more into the direction of making use of digital technology, that should be really looked at, and people should also become more flexible maybe to indeed say, yes, this can be done by a certain level of health worker with backup from from specialists or other cadres that are needed. So yeah, I think that's how I look at it for now. Thanks.
Ivana, if you're speaking, I think you're on mute.
Yeah, sorry. I thought I had unmuted myself. I was just saying, somebody said to me the other day that they thought the medical system was one of the most hierarchical systems in the world, where, you know, your kind of specialisms and your expertise really kind of define where you sit in the system and what, you know, what you can do and that sort of thing. And I guess that, amongst other things, is also changing slowly but surely.
Yeah, I think.
Well, I think if I could come in just a second, I think we ought not to ignore the power dynamics here of when definitions and categories of professionalization change. So, for example, I don't know this one very well, but if I remember right, I think in the Alaskan community health systems, at one point in time, they decided to add dental, probably some basic dental care to the community health workers there, and there was a lot of sort of guild-like pushback, right, from the Dentist Association, which is very understandable. But I think for each sort of step along the way in this evolving world of professionalization, I think you'll probably hit some of those tensions as well. And I very much agree with where Reg and Maurice were saying about the sort of infrastructural pieces of this work. And but I wouldn't forget also the policy architecture here, where just to give you an example, in Zimbabwe, one of our colleagues is working on their community health strategy, which is I think probably just more recently developed. And they were coming from a place where there were 77 or 77 plus different cadres of community health workers, all working in different ways, some working on malaria, some working on family planning. And in that situation, there's sort of such a fragmentation there that you need a little bit of centralization of policy coherence before you can then make these gains in execution. And so I think it's probably place by place, but we want to see which evolutions of the policy architecture, in this case, like those pipes are just like, so there's like way too many of them, perhaps, before you can get to that like real effectiveness that both Reg and Maurice were talking about.
So some need for kind of standardization as well.
I mean, I think it's a tension, right? You don't want to go so centralized that you aren't fit for purpose. But I think case by case, you might want, and it might be an evolution of going to a slightly more standard, consistent model while you learn to then move toward this decentralization. But I think I think it would be a mistake to ignore the sort of upstream policy stuff. And then similar thing goes to the financing. How money flows really can fragment a system as well.
And any favorite innovations right now? If each of you had, I don't know, 100 million, that'd be nice, no? Where would you put it in this system to support transformation?
I'll kick it off. I mean, I know I talked a bit about virtual care and that aspect of things and connectivity, but honestly, I think it's more around finding solutions that can be implemented in communities that can work off grid. That's where I think the big opportunity is, because then that way, to your point, Nan, you can create collectives around those capabilities, centralize where you need to, where it needs to be done, but then offer services in a decentralized model if you need to. I think that's the big barrier right now that we're starting to see is that to access certain types of care, there's just certain levels of infrastructure that you need, and that's very, very costly. And so, in our Western world, to get access to XYZ, you actually need to have a hospital. Otherwise, you can't get access. And I want to disrupt that model and say, you don't necessarily need a hospital. You don't necessarily need a clinic. So can we start creating these technologies that are self-contained, that can be used by communities, preferably off-grid if you can. I think that's what's going to really change healthcare. That's where I would put dollars.
Yeah, well, as for me, I'm not so much into this subject, but I have seen that quite simple technological interventions like that are connecting different health workers to each other in terms of training and supervision as well can really make a huge difference in motivation of health workers and also the quality of care that they can provide. So I would put quite some of the money there as well.
Yeah, I like that. I like those. I'm just going to see if I can. So on that, and I might have a second favorite. We'll see. There's I think there's something to be said about the interface between health information systems, that data, and then the training, supervision, and sort of adaptive design of that. So it's almost like if you can connect those three together, where the community needs or new epidemics or new diseases or even current diseases, hotspots are shown in the info systems that then go to like a supervisor and it says, hey, in my sub-district, this thing is epidemic is happening, and the curricular or educational system content is already there too, to say, hey, I haven't seen an outbreak of measles here for a few years. So I'm a little bit rusty on that. How do I train myself and my community health workers to do that now? I think connecting that would be, and probably the hardest part about that is not even the individual systems, but the interoperability of all. And if I could mention one other thing is slightly more upstream at the ecosystems level. And this is where I've seen, actually, I think there's a project in Kenya called I can't remember, the acronym is CHU for UHC, but it's like an ecosystems approach where government, local NGO actors, deliverers of healthcare, and community civil service organizations kind of all work together, and which recognizes this future where, while maybe a government has a mandate to provide this for their public and their constituents, it's going to be a very diverse group of people who will actually execute on it, and deliver back the feedback to keep executing. So these ecosystems approaches, which are a little less shiny, a little less interesting to invest in for some, I think that's where a lot of the future, the big bang will be.
Yeah, I get you. They're tougher, aren't they? Less shiny, as you say, but much more systemic than in terms of the kind of networked effect that they can have. So I hear that. I hate to say this, but I think I might kind of wrap us up now because we're nearly to time. And I'm sorry because it's an amazing conversation. But I did want to kind of reflect back some of the stuff that I heard that I thought was kind of particularly fascinating threads through this conversation, starting with, this idea that there is lots of really interesting practice, lots of examples to learn from, and that the trickiness is really in kind of how do you move from small scale, good quality examples to at scale for that same stuff. And in particular, I think Maurice was bringing in the point around kind of grassroots innovations and bringing in the perspective of the frontline workers, because they are often seeing and learning and knowing stuff that doesn't necessarily play its way back into the system. Loved Reg's point about kind of data really being about culture change, not about the actual raw data sets. And so how do you, beyond collecting the data sets, how do you utilize that effectively and teach different bits of the system to think differently about those data sets. And the point also around kind of the diversity of healthcare workers. And this came up, I thought, through several different points, but the idea that in order to serve equitably a diverse population, that you needed to kind of reflect that in the workforce. Prevention infrastructure, wireless infrastructure all felt like strong themes, as well as also this idea of like creating teams and team building, so that community health workers were supported through a network of other practitioners as well. I'm going to stop there because I've probably not picked up on everything, and I also want to give each of you a chance for any final reflections if you've got them at this point. Is there anything that struck you in particular? Anything surprised you about this? Anything we've missed that you want to throw in last minute? Silence is golden.
Last thought is I've really enjoyed this conversation. It sparked my curiosity a lot, and it makes me think that part of the path forward in many of these systems, whether at a local or regional level, is that shared learning, that shared curiosity, where whether it's something like this or that shared curiosity around actual data that's flowing, what we ought to be doing for it or by it.
Thank you. Agreed.
Yeah, same here. I really like the discussion, shared learning, and I think also joint action, that different levels within the health workforce work together for the same goal. That's after all what you want. Yeah, and that can have different ways of doing that. I was just also thinking about how health workers, for example, could use technology or also, expose themselves a bit more in the discussions around health at community level or at national level. For example, there are currently here in Malawi quite some misconceptions around COVID-19 vaccinations and healthcare around that. And a lot on social media, a lot of things, and there's not really a joint active movement from the health sector or from the wider health sector to counteract that somehow. So also action, joint action to promote health and to inform and contribute to the debate nationwide and globally as well.
Brilliant. Thank you. Anything from you, Reg, before we close?
Sure, I'll just make a quick comment, and it kind of builds off what Maurice was saying. I think, look, we've seen significant global disruption in different sectors, banking, media, transportation. We're going to see the same level of disruption in health, and it's going to be really interesting over the next couple of decades to see what kind of health systems come out of the back end of this large disruption that we're on the tip of.
Yeah, so true. That's an interesting, we didn't talk very much cross systems, but I do think you're right that we're at some kind of tipping point right now. I don't want to say in the wake of COVID, because we're not, right? But we're kind of starting to see lessons emerging, which is part of the reason we thought this would be a good moment to convene some of these dialogues. And on that note, I'm going to close this conversation, but also just to say, join us again next week, please, for the final conversation we're hosting, where we're actually going to examine the question of what is the future healthcare workforce that we need in a little bit more detail. And obviously, you can sort of tune in and follow all the conversations and the writing and the dialogues of the project on thefuturecenter.org. Thank you.
Thank you.
I think that is a wrap for us.